Very good afternoon, everybody. So today we have a very interesting case from Surgery Unit 4 from Department of Surgical Disciplines. Before we start with the presentation, I'd like to just quote a dialogue by Robin Williams from the movie Patch Adams. He says, as doctors, it's not just our duty to treat the patient, but our duty is to improve the quality of life. If we treat a disease, we might win or lose, but if we treat a patient, we'll always win. With these words, I'd like to now call upon Dr. Shweta, junior resident from our unit, who shall be presenting the clinical case, followed by the surgical part will be discussed by Dr. Bijesh, the review of literature by Dr. Sai, and will be helped by our friends from Department of Anesthesiology, from Radiology, and from Pathology. Dr. Shweta, please.
Thank you, sir. In the world of surgery, the unexpected lies beneath the surface. So, today we uncover one hidden intruder, the one that survives at our expense. So, welcome to our mystery, the parasite. With this, a very good afternoon, everybody. We, Surgery Unit 4, will be presenting our journey through a very interesting and a very rare case that we encountered. So it all started with a fine day in our OPD when a young boy, Mr. N, 16 years old, he presented to our OPD with his hands on his abdomen and something hanging out of his clothes. So at first we thought that if he is carrying his sibling, so as soon as he exposed himself, we were surprised, rather shocked to see that he indeed was carrying his sibling in the form of a parasite throughout his life. The chief complaints were extra limbs coming out of the upper abdomen with preserved sensations. Both the extra limbs, they were growing along with him throughout the life. There were sensations of touch, temperature, and even pain in those limbs. There were no medical comorbidity in our patient, and there was no surgical history present. The family history was unremarkable because there was no history of any twin birth on either side of the family. His birth history was as follows. It was a non-consanguineous marriage. The pregnancy was not registered. He was born at home, full-term normal vaginal delivery. He cried immediately after birth, and there were no postpartum complications in the mother as well as the child. We have got a very limited pedigree. So he was second in line, and his elder brother was not. He achieved all the developmental milestones on time as per the informant, which was a paternal aunt for us, as we were not able to get his parents at the moment. Coming on to the examination, we have autocyte as well as the parasite examination. So the patient was very cooperative during the general physical examination, and there was no pallor, icterus, cyanosis or clubbing in our patient. The systemic examination was also normal, with cardiovascular and respiratory system were normal. His higher mental functions were intact. There was no sensory, motor or autonomic dysfunction in our patient, with normal deep tendon reflexes as well as the powers in bilateral upper and lower limbs. So he was fully developed without any spinal deformity. The additional limbs were coming out from the epigastrium attached to his leafy stomach. His male external genitalia was fully developed, on contrary to his parasite twin, which we will be seeing in a while. The hernial sites were intact, his umbilicus was deformed, and there was about 12 cross 10 centimeter lump which was palpable in the right side of his abdomen, which was slightly crossing the midline and was ballotable with well-defined margins. Coming on to the highlight of the presentation, it is the parasite and its examination. So it was fully developed with two lower limbs, two legs, 2 feet, and 10 toes, in which the first and second toe they should syndactyly. The natal cleft was not separated. There was ankylosis of both the joints, and the movements were just passive only. So here absent anal opening. There was micropenis with the scrotal sac being empty, and the sensations of touch, pain, and temperature was present, as I already mentioned, and there were no deep reflexes in this parasite. So what kept us going, even after knowing that this is going to be a very complicated case for us, was the journey of our patient. So we knew that he was going through a roller coaster of despair after being abandoned by his mother at a tender age of 1. He was constantly being mocked by his peers, so he had to drop out of school in class 8. The discomfort which he used to feel even while doing the routine activities like standing, walking, or even going to washroom, we cannot even imagine that. His father took him to several hospitals just thinking that there would be some treatment, but he always returned disappointed. So, what was the need of the moment for us? It was a proper planning which will come out of a thorough evaluation of the patient. We needed to delineate the anatomy well because we cannot plan a surgery without that. So, we did a CT angio for that. And there was a multidisciplinary coordination which was required because this was not going to be a solo dive for us. So we did routine examination, evaluation as well as the hormone profile in the patient which were normal and his hemoglobin was around 15. We also did tumor markers which were normal except for CEA which was slightly raised. His echocardiography was suggestive of mild tricuspid regurgitation in our host. So now we have Dr. Anand from Department of Radiology to decipher the CT angiography of the patient. Anand?
Very good afternoon. I'll be discussing the CT angiography for the patient, which was done on 31st of January 2025. In these representative sagittal images, we can see that this is the parasite that is attached to the otocyte with the help of a soft tissue stalk. And it is also showing bony attachment to the upturned Ziffy sternum of the otocyte. These are the representative axial images. In this, we can see that the parasite consists of a dysplastic cystic structure, which could represent the bladder, two ovoid cystic structures, which could represent the testis, a dysplastic pelvic girdle, as well as external genitalia. And on these volume rendered 3D images, we can see that these are the bilateral limbs of the parasite. On these axial maximum intensity projection images in the arterial phase, we can see that the right internal mammary artery is prominent, and it is CV to supply the parasitic limb. It divides and supplies the bilateral parasitic limbs. There is also an intra-abdominal multilocular cystic structure which is showing peripheral internal calcification. It is showing communication with the parasitic limb through an anterior abdominal wall defect. It is also displacing the adjacent visceral organs, the liver, the bowel loops to the left, and the pancreas posteriorly. However, we can see that there is no gross invasion of these visceral structures. So to summarize, the parasitic limb is attached to the Ziffy sternum of the otocyte, receiving arterial supply from the prominent right internal mammary artery. There is an intraperitoneal cystic lesion communicating with the parasitic limb through an anterior abdominal defect, compressing and displacing the adjacent visceral organs, which could represent the remnant of the vestigial twin. Thank you.
Thank you, Dr. Anna. So we have the diagnosis of heterozygous twin and we plan to excise and do the reconstruction. So at this point of time, we knew that the surgery was not going to be a cakewalk for us. And as surgeons, we deal with the challenges in three phases, in the preoperative, intraoperative, as well as the postoperative phase. So the preoperative challenges that came were in the form of the preoperative optimization, for which we have to build up the nutrition in the patient and the arrangement of adequate blood and blood products. There was a question that was constantly bugging our mind. It was which one to take out first, the parasitic limb or the abdominal mass which we have. So we came up to a solution for this. And after that, there was yet another question that was what would be the position of the patient on the table, because it is very important for the safety of the patient as well as for the feasibility of the surgery. In the intraoperative phase, we have the challenges like there could be excess blood loss because about 20 to 30% of the blood supply of our patient was in the parasite. So he could land up in intraoperative hypotension. The CT angio did give us some hint about the intra-abdominal anatomy and the relations of that structure. But as I already mentioned in the beginning, that in the world of surgery, the unexpected lies beneath the surface. So what exactly was going to be the exact anatomy as well as relation, we will be finding out after the during the intraoperative period. And there could be the need of vascular as well as abdominal wall reconstruction, for which we had our plastic surgery colleagues on standby. So no surgery is a success if we don't take into account the post-operative challenges as well as the complications. So there could be the need of ICU admission and mechanical ventilation in our patient, as well as the patient might feel the sensations of phantom limb in the post-operative period. After addressing all the challenges, we came up with a collaborative surgical strategy with our anesthesiology, radiology, plastic surgery, and pathology colleagues. So now we have Dr. Rakesh for the anesthesia concerns about the case.
Good afternoon, everybody. So in this case, from anesthesia point of view, already perioperatively the surgery team already planned. For my side, what we'll do first, we things are correctable things. The correctable things is the anemia. So first we correct the anemia. We already corrected the anemia by nutritional buildup, and then we plan for anesthesia plan and post-operative care. For the anesthesia plan, we plan for the general anesthesia and the epidural, because this is going to the big incision. Firstly, secondly, this patient has the sensation, so there is possibility the patient developing the phantom limb pain. So that can be maintained or some decrease by using the epidural or the acceleral. Then we hemodynamic monitoring, because this parasitic limb is receiving the 30% of the blood volume. So as soon as the surgeon clamp the vessels, patient has sudden blood loss of the 30%. So equivalent to the class 3 of the hemorrhagic shock. So for that we plan to do the invasive monitoring with the advanced hemodynamic monitoring with PPV, SPV, and the extra volume variation with the hemostatic. Then we arrange the blood and blood product, because we now know how much blood is going to lose. Then we also plan the surgical thing, what they do. Either we will remove the limb first, or they remove the internal part. Then we plan the first, after dissection, we identify the vessels and the first clamp vessels, how much patient VP fall. Because this is all assumption, the patient receiving 30% blood volume, 20% blood. So once you clamp it, not cut it, clamp it, we see how much. So initially after clamping, the nearly 20%, 25% BP fall. So we step up the vasopressor by increasing the vasopressor requirement. We already patient on the 2 vasopressor intraoperative for tangent time nearly 15-20 minutes. So intraoperatively we do the extender monitoring. Apart from in this, we use only the advanced monitoring for the beat to beat variation and the changing the volume of the patient. So intraoperative, our concern, we have to prevent the hypothermia, because once you give the fluid or any product, patient will go into the hypothermia at any cost, because there is large incision, 50 temperature is. So whatever you measure take it, patient will go into hypothermia. Secondly, the sudden loss, there is possibility the poor perfusion, patient go into acidosis. Then coagulopathy, because we transfer the blood product. So if the acidosis and hypothermia happen, the coagulopathy will get worsened. And once you transfer the large amount of blood, suddenly the patient may develop the hyperkalemia and hypocalcemia. It's common. So we taken all these measures by giving the adequate blood and blood product, fluid, and the vasopressor. Then we already discussed how we prevent the loss. We maintain the low blood pressure, low normal, 90 to 100 systolic SBP. And then we elevate the limb before clamping, so that whatever the some amount of blood is in the parasitic limb, that go into the circulation. And post intraoperatively, we manage the analgesia with the epidural and the with the paracetamol NSAID. And post-operatively, we kept on the ICU for 48 hours with the continuous infusion of the local anesthetic and the fentanyl. So patient then extubated on table, but patient required the significant pain management and contamination for the next 48 hours, and then 48 hours patient discharge.
Thank you, sir. Coming on to the final showdown, that is the surgical part. So now we have Dr. Brajesh to elaborate the steps of surgery for us.
Thank you, Dr. Sudha. I will be describing the steps of surgery for our cases. We had three intraoperative goals. First, resection of the parasitic limb or stalk dissection. Second, abdominal lump excision. Third is wound closure. After proper preoperative planning, patient was taken in the OT. Patient kept in the supine position under general anesthesia. Painting and draping was done, and extra limb was also separately painted and draped. For first removal of the parasitic limb, which was attached to the defied portion of the sternum, we give a circumferential incision. Incision was deepened and subcutaneous tissue was dissected carefully with blunt and sharp dissection. Firstly, we noticed a large artery, as you can see in the video, which was dually ligated and divided. The artery, after the arterial division of artery, subsequently vein was also ligated and divided. The arterial supply was, as per the CT angiography report, was coming from the internal mammary artery. Further dissection of the tissue, circumferential incision was extended and tissue dissection was carried out. During tissue dissection, we identify multiple collaterals, which was individually ligated and divided. Further remaining tissue was stalk was dissected, during which we found some bladder-like structure, as you can see in the video, in this part, and we also found a soft tissue mass, which could be a testis or prostate. Rest of the stalk was clamped, transfixed, and divided with harmony. After the removal of external limb or parasitic limb, we proceeded to second part of the surgery. In which we remove the abdominal, for which previous incision was extended midline to abdomen as like laparotomy. Layer by layer dissection carried out and abdomen was open. After which we noticed glistening white huge large mass, which was adherent to the surrounding structure and anterior abdominal wall. These addition was dissected carefully and anterior abdominal wall addition was also carefully dissected. While delivering the cyst, we also found a dense adhesion over the anterior to the liver. These are the adhesions which are carefully dissected out. Now we can see this is the dense adhesion over the anterior part of the liver. This was separated. After that, cyst was successfully removed. This is the liver and strong adhesion. This was successful. After that, we also excise the jetting out sternum part. Fortunately, there was no other visceral communication, but during further visceral inspection, we found the large white urachus, patent urachus, which was ligated and divided. After that, we achieved the hemostasis, and a subhepatic drain was placed. After the surgical process, in discussion with plastic surgery team, they suggest that no need of the abdominal wall reconstruction for this patient. So abdomen was closed in mass fashion with help of the double leg suture and continuous loop knife. These are the operative specimen. In first specimen, we can see the intact cyst mass with bladder of the parasite limb. This is the bladder, and this is the cut down specimen of cystic mass. Now I would like to invite Dr. Salni for the step.
So this was the specimen what we received in our department. This was the two limbs we can see with external genitalia and the separately lined cystic structure was there. Sections of cystic structure show gut wall. This is the muscularis propria and the thinned out muscularis mucosa. And submucosal fibrosis was there, but definite lining epithelium we could not identify. It was resolved and showing mucin only. These were the collection of mucin and there were lymphocytic infiltrates in the wall. These are the mucin with foreign giant cell reaction, prominent hyalinization of the wall, focal areas of dystrophic calcification were identified. The foreign body giant cell. We could identify the bladder, sections from which showed urothelium. Broadly, the sections from penile region, this is the skin, corpora spongiosa. We could not identify the prostate broadly, but on microscopy, we could see here, these are the benign prostatic glands. And these are the sections from the bone, which were under marking. Thank you. Thank you, Dr. Shalini. Coming on to the post-operative course of the patient, which was rather smooth. Though he was kept in ICU for post-op day 0 and 1, but he was hemodynamically stable throughout. He was allowed only on post-op day 1. The drain was removed on post-op day 3 and he was discharged on post-op day 4. So we have seen the journey of the patient before the surgery. surgery. So after the surgery, firstly, he was not able to comprehend the reality that finally he will be able to live a normal life after so many despairs and hopelessness. And his family was overjoyed with the tears of joy. So coming on to the review of literature, now we have Dr. Sai Krishna.
Thank you, Thank you, Shweta. Good afternoon, everyone. This was a very peculiar case and a rare one, and so is the literature available on it. Most of the literature was found on conjoined twins, but there was a dearth of literature on these heterophagous kind of conjoined twins. To understand this, let's first understand what is a conjoined twin. You can recognize these two prominent figures, Eng and Chang Baker. These were the first conjoined twins who were studied extensively and researched and in our literature available. What are conjoined twins? Conjoined twins are twins which are joined in utero. It is a very rare phenomenon and is estimated to occur in 1 in 2 lakh births and is predominantly seen in female genders. Approximately half are stillborn and additional 1/3 die within 24 hours. Let's know how a conjoined twin is formed. To know how a conjoined twin is formed, first we need to understand the formation of a normal twin. What happens is when the zygote undergo differentiations, the yolk sac is formed, and at days 13 to 15, this yolk sac gets separated, and this leads to formation of twins in a monochorionic, monoamniotic type of zygote. But what happens? There are two theories which suggest this conjoined twins formation. One is the fission theory, which states that this separation of yolk sac doesn't happen and leads to a fused yolk sac, leads to those twins joined at one place. This is the most accepted theory. However, there is one more theory which also suggests that initially they are separated, but they fuse due to some insult in the uterine period. This theory is fusion theory, but this is highly not acceptable. This is how a conjoined twin is formed. But how do a heterophagous kind of conjoined twin is formed, which is popularly by a trap sequence? This is this trap sequence. To understand that, we should think there are two twins in which one of the twin lacks a heart, brain, and everything. So this twin is indirectly dependent upon the other twin for its blood supply. So over a period of time, due to this, it gets resolved into the normal twin, leading to the formation of heterophagous twin. The blood supply of this twin is entirely from the normal twin. The blood from the normal twin is utilized by himself first and then he gives. So the blood supply which the parasite receives is a deoxygenated type of blood and it renders it malnourished. This is the blood supply I was talking about. The blood. Now, coming to the classification on the based on the fusion sites and its epidemic and its incidence, it was seen that there are many types of conjoined twins like thoracophagous, omphalophagous, heterophagous, and craniophagous. You can see that the heterophagous type of twins were only 20% of these cases. The point here to be noted is that out of the 1 in 2 lakh births we see, heterophagous accounts for only 10%. You can see the rarity of the cases to occur. The parasitic twins has two parts. One is the parasite, the undeveloped twin, who remains vestigial throughout his period, and the independent twin is called the autocyte. These are associated with certain complications which can be divided into birth and in uterine and as well as long term. At birth, it can lead to premature labor and it can lead to stillbirth, polyhydramnios, and maternal complications such as gestational diabetes mellitus and preeclampsia. And at birth, it can lead to mortality due to prolonged labor, breathing difficulties, cardiac overload, organ failure, and infections. The long-term complications associated are due to its own weight, that are due to scoliosis, cerebral palsy, developmental delay, and mental health issues. After removal also, there are few certain complications like SSIs, injury to the internal organs of the autocyte, failure to remove complete parasite, and intra and post-op hypertensions. How to detect this case? USG is the most reliable method to detect anomalies and it is generally done in 16 to 18 weeks. But if at all any doubt, we can go for MRI, which is a safe alternative option. Postnatally, though we can see there are visible parts, but we need to confirm the anatomy of the anatomical delineation. We need a CT and X-ray to do it, and we have to perform genetic analysis on these individuals too. After detecting, what is the treatment? The treatment of it is simple, surgical excision. And in whatever cases it is not possible, we have to go for supportive care. The treatment, the surgical excision is itself a challenging thing, and we are facing, we face many challenges throughout this period. What are the challenges we face? So it is a rarity and its complexity of the anatomy. Multidisciplinary approach might be required in these cases. Surgical challenges such as anatomical variations, vascular supply, tissue reconstruction, and a requirement of stage procedures. And post-separation, post-separation, these challenges like ongoing health issues, urinary problems, spinal cord anomalies, neuropaxias, long-term follow-up, and last but not the least, the cultural and ethical considerations. This was the only paper we find in which they have reported around 44 cases of epigastric heterophagus twins worldwide, and our case marks the 45th. And what they found is that, as in our own case, it lacked in 87.8% of the heterophagus twins. It lacked brain, heart, and lungs. And so, and in like in our case, there was imperforate anus in 43.9%, and it is also connected to the liver and sternal cartilage around 44%. What makes our case a peculiar thing is that the presence of the intestine within the host, that while discussing the pathology, they have told that there was a few GIT epithelium was found inside the abdominal cavity in the cyst. This makes our case very peculiar. The medicine is not all about healing. It is to restore the place of the patient in the general society. Now, there are to emphasize on that. Here is a small documentary made by BBC. We would like to show you.
तो दिक्कत थी वो हट गई, डॉक्टरों ने हटा दी। मुझे बहुत अच्छा लगा डॉक्टरों से।
जब पढ़ाने भेजते थे, अब वहीं अब स्कूल में बच्चे जानते हो, मारना कूदना, ये लड़ाई करना, कहना पापा सब परेशान करते हैं। मैं कह रहने दो।
We first separated the limb. So as soon as we separated the limb, there was a fall in the blood pressure. You can imagine almost a 16 kg limb lying outside, taking almost 20 to 30% of the blood supply of the host. Then once we detached it, we went inside, we took out the part which was lying inside the abdomen of the host, and fortunately there was no adhesions or attachment with the intestine, and we were able to successfully take it out. Lot of people maybe shunned him. He was social outcast. He had to leave his school. But now, as soon as this has been removed, he has been completely cured of his physical problems and as well as the mental problems that he was facing because of his condition.
एक ईश्वर ऊपर वाला है, ये दूसरा एम्स के डॉक्टरों हैं। ये कुदरत से खाली नहीं है।
Now, the take-home message from this case is that we can face many rare conditions, and like this, and this is the surgical management is the best part, and we require multidisciplinary approach. Normally, these kind of cases gets operated within 1 year of the birth, but this was the first case which was operated at the age of 17. Now, I would like to call Dr. Professor Suri Krishna sir to say his final comments and conclude the meeting.
Thank you, Dr. Sai. I think so this presentation will not be complete without acknowledging the effort of all those people who were involved in this multidisciplinary. I'd like to first acknowledge Dr. V.K. Bansal. Actually, he has been our mentor and guru, and whatever we have been doing, we have learned from him. I'd like to thank Dr. Manish Shingal and his team from plastic surgery for providing this support. Even though we didn't require, they were always beside us, helping us out. A surgeon cannot do his surgery without the help of anesthesiologist, and a thank to Dr. Ganga, Dr. Rakesh and his team. and Dr. Atin and Dr. Ankita, whom we have been pestering for the last so many years, and they have been always find time to help us. Dr. Rajni from Pathology, and last but not the least, all the residents from Surgery Unit 4. Thank you very much, and I'd like to open this for comments. Sumba sir.
It's very great.
So conjoint have been done, but this is the only one with heteropagus which is.
Because sometimes back there was some muscle in the movie.
Yes, sir.
I was wondering, Krishna is up to making a movie or what? And it's a rare case and I must the whole team of residents, faculty members involved who have put in an effort to this very successfully. So congratulations to all.
Thank you. Thank you. Sharma sir. So, if there are no further comments, thank you very much.